Okay, so this is the third video on the gastroesophageal reflux disease. In this video, I'm going to talk about the management of Gerd. Okay, the management of Gerd constitute three lines. The first one is the lifestyle modification. I'm sorry. Okay, let's just get that. Okay, the lifestyle modification. How can we modify the lifestyle of the baby to relieve the gastroesophageal reflux disease? The first thing is about the position, okay, and the food, okay, and the weight loss when indicated. Okay, before I continue lifestyle modification line of treatment of Gerd, I want to mention the other lines of treatment. The first one is lifestyle modification, the second one is medical management, and the third one is the surgical management of Gerd, and each one of them actually has some indications to apply. Okay, let's get back to the lifestyle modification. What is the optimal position to relieve the Gerd symptoms? Okay, we have less gastroesophageal reflux disease in a prone position with the head tilt up or sloped up of about 30 degree. Okay, so prone position, the 30 degree slope of the head. But you have to pay attention that before 1 year we can't just get the baby to sleep on a prone position, because we have a high incidence of sudden infant death syndrome, okay, in a prone position baby. Okay, so the prone position is applied on over 1 year babies, not before that. Before 12 months the optimal position is supine position. The sitting or semi-sitting position actually, or semi-supine position, will increase gastroesophageal reflux disease. So if I ask you what is the optimal position for baby with gastroesophageal reflux disease, if he above 1 year, it is a prone position with the head up, slope of 30 degree. What is the best position for less than 12 or 1 year baby? It is the supine position. This is the first line of lifestyle modification. Second one is food. The thickened food formulas are just better than the non-thickened one. Okay, so like extremely hydrolyzed formulas, for example, very good. Okay, you have to add some thickeners like carpal, okay, nestigral. They are all great. If you thicken food, that will delay that will make the emptying process better. Okay, so it will decrease gastroesophageal refluxing. Okay, you have to give appropriate volume of feeding. It will the best thing is to give small frequent meals, but take care not to underfeed the baby. Okay, you have to avoid fatty food in older children. You have to avoid feeding before sleep. Okay, there must be a time between feeding and sleeping. Okay, so these are the main advices for food: thickened food, appropriate volume, small frequent meals. Okay, avoid feeding before sleep, avoid fatty and carbohydrate feeding. Okay, the third line is more to adults. They have to avoid alcohol, smoking, okay, passive smoking for children. All these are the most important thing to modify in lifestyle modification of Gerd: the position, the food, and the weight loss, very important, alcohol and smoking modification. Now let's move to the second line of management of gastroesophageal reflux disease, the medical management. Actually, there are multiple drugs that we can give to avoid and to treat the gastroesophageal reflux disease, like gastric anti-secretory agents. You know, the main problem in most cases of gastroesophageal reflux disease is of about the gastric acid secretion. So if we suppress the acid secretion, then this is very good way of treatment of gastroesophageal reflux disease. Mucosal protectors also, some drugs that protect the mucosa from the effect of the acids or the gastric secretion. Prokinetic therapy works on enhanced gastric emptying, increased lower esophageal sphincter tone, and so on. Okay, let's now start with the gastric anti-secretory agents or the acid suppressants. Okay, we have mainly two acid suppressants. Before 1 year, we have to give, or we can give, H2 receptors antagonists, and for more than 1 year you can give a proton pump inhibitor. Proton pump inhibitor actually is better than H2 receptors antagonist, but you can't give proton pump inhibitor before 1 year. Before 1 year you have to give H2 receptors antagonists like ranitidine. What is the mechanism of action of H2 receptor antagonists? I will show you in this video. Okay, let's watch it together.
Acid secretion by gastric parietal cells initially involves stimulation of histamine, acetylcholine, and gastrin receptors, shown on the interstitial basolateral surface of the parietal cell. Stimulation of these receptors triggers a sequence of events. Water and carbon dioxide inside the cell, under the influence of carbonic anhydrase, shown as curly gray, form protons, red, and bicarbonate. The bicarbonate exchanges the chloride on the interstitial surface through a chloride bicarbonate exchanger. The proton heads for the luminal side proton pump, and under the influence of ATP exchanges for potassium, while the chloride ion exits into gastric fluid through a chloride channel, shown in green. When we introduce ranitidine, it blocks the histamine H2 receptor. This blocks the entire sequence of acid production and relieves symptoms.
Okay, so this is the mechanism of action of H2 receptors blockers or histamine receptors blockers like ranitidine. It has some kind of tolerance, but in proton pump inhibitors there is no tolerance. Okay, so it is the beneficial thing about the H2 receptor blockers or antagonists that they have rapid onset. They are very useful for on demand, okay, and they are more safe to be used than the proton pump inhibitors. Okay, what is the mechanism of action of proton pump inhibitors? In this video I'm going to show you that.
The inner surface of the stomach is formed into numerous gastric pits from which acid is secreted. The cells lining the gastric pits are mucous neck cells, which secrete mucus, the G cells, which secrete gastin, the parietal cells, which secrete hydrochloric acid. The proton pump present in parietal cells is responsible for acid secretion. The proton pump is located in the luminal side of the parietal cell. Proton pump, proton, potassium, ATP. The proton pump actively transports protons into the stomach lumen and potassium back to the parietal cell with hydrolysis of ATP. Proton pump inhibitors are drugs which reduce acid secretion of the stomach. The drug binds irreversibly to the proton pump and prevents the active transport of proton. This dramatically decreases the acid secretion of the stomach.
Okay, so this is the mechanism of action of proton pump inhibitors. They are superior to H2 blockers for healing of erosive esophagitis, okay, and relief Gerd symptoms. So they are very good or better than the H2 blockers for the severe erosive esophagitis cases. Okay, as I said, they have no tolerance. Okay, once daily for most patient is extra well. Okay, the three examples of proton pump inhibitors that are given in children are lansoprazole, omeprazole, esomeprazole. Okay, lansoprazole, omeprazole, esomeprazole. Proton pump inhibitors actually have some side effects like hypochloridria, okay, drug interactions with other drugs, headache and diarrhea, and also B12 deficiency that will lead to hip fractures. Okay, in adults we have acute interstitial nephritis. The most important things to remember in children: the hypochloridria, okay, the B12 deficiency, and so on. So this is the proton pump inhibitors. So H2 blockers, proton pump inhibitors, they are anti-acid secretory drugs. Also we have mucosal protectors to be used like sucralfate. Okay, they are rarely used for gastroesophageal reflux disease. Also prokinetic therapy. Prokinetic drugs are drugs that enhance gastric emptying by the movement of the gastric muscles and peristalsis of the esophagus. They increase the lower esophageal sphincter also tone that will prevent the recur or the regurgitation of food from the secretory things from the stomach to the esophagus. So by these two mechanisms, the prokinetic therapies like metoclopramide, erythromycin, domperidone or motilium, okay, metoclopramide, erythromycin, and the motilium, by these two mechanisms can improve Gerd, but actually they are of minimal real benefit. Okay, the surgical management, the third line of management after the lifestyle modification and the medical management, is of some indications like failure to optimize medical therapy. The medical therapy is not enough to treat the condition for more than 3 months. Okay, after 3 months of medical therapy we have no enough improvement. Dependence on long-term medical therapy. Okay, sometimes medical therapy have some kind of dependence. Okay, and this condition we move to surgical management. Severe non-compliance to drug. The patient is non-compliant to his drugs, and this is an indication for surgical treatment. Stricture of the esophagus, okay, or recurrent aspiration pneumonia or severe esophagitis. So things in esophagus that may indicate the surgical management are severe esophagitis or paresophagus, the stricture of esophagus. Okay, in the respiratory system, the chronic respiratory complications like pneumonia and other thing, okay, indicates the surgical management. Also the failure to optimize medical treatment, okay, the dependency of the treatment. What are the surgical maneuvers to be done? We have Nissen Fundoplication. Okay, the Nissen Fundoplication is a procedure that just bend the stomach on the lower esophageal sphincter to prevent the reflux. Okay, this video is good to explain what is Nissen Fundoplication. Okay, we have two approaches to Nissen Fundoplication. The first one is the open approach. Okay, so this is the stomach, this is the lower esophageal sphincter. They just bend the upper part of the stomach over the lower esophageal sphincter and stitch that to prevent the reflux from the stomach into the esophagus. The second and the less invasive procedure is minimal invasive procedure is by laparoscoping to do the procedure. Okay, so this is laparoscopy procedure. The same thing is done. They bend the stomach above the lower esophageal sphincter. So this is the Nissen Fundoplication. Okay, so this is the surgical procedure. In severe neurological defect that we cannot tolerate the oral or gastric tube, the the child cannot tolerate the oral gastric tube, we can use feeding jejunostomy. Okay, feeding jejunostomy. So this is all about the management of gastroesophageal reflux disease. By this we end the whole thing about the Gerd. Okay, we talked about many subjects in Gerd in details, and so that's it. Thank you very much for watching. See you in next video.